Pabarangong, Narajari Rui. G'day, my name is Paul Worley. I'm a rural doctor who works at Murray Bridge, which is on Narajari country.
Nanawi Michi Renee Krupinari. I'm a proud Narajari woman. I live in a small Aboriginal community called Raukin, and I also live and work on Narajari country.
And we would like to recognise elders past, present and emerging here. And one of the things that we love about coming to New Zealand is that I think much more integration between Māori and Pākehā culture than we have in Australia, and I hope we can learn from that every time we come here. We don't live and work in Adelaide. It's close, but we actually live and work in a rural local health network, the headquarters of which is about a 3.5 hour drive from Adelaide. We are from the Ministry of Health, and we're here to help you. No. We are here from the group that I haven't heard mentioned this morning, and that is the non-primary healthcare sector. And we want to tell you a story about what we are doing in that non-primary healthcare sector that might help answer some of the questions that you've been asking about how do we get doctors to change? How do we get the system to change? And can I suggest to you that if we just stay in our comfort zone of primary care, the system won't change. So, we have formed in our local health network because we recognised that we were having crisis after crisis after crisis. And what were those crises in? They were mainly workforce crises. We just couldn't get people to come and work in our area. We couldn't get them to come and work in our hospitals or in our primary care facilities, in our community health. And we can have all of these great ideas about what we should be doing and policies that we should be putting in place. But if we don't have a workforce, that's just cruel, because we're just making people feel even more shamed that they can't be doing what they should be doing, because they're just chasing and chasing and chasing just to keep up, just to keep the rosters filled. So what's the usual response to that? Pay more money. Pay more money, blame the government, pay more money, and recruit people who can't go anywhere else. In Australia, we've done that par excellence. We've robbed so many different countries that we actually have reverse foreign aid to many of those countries with the number of doctors that we have taken out of those countries to come and work in our areas. And some of those have been fabulous doctors, not criticising the doctors. But the policy, what it said is, there's something wrong in the bush. And you only go there if you can't get a job anywhere else. So we decided to change that narrative. And instead of having the Riverland Academy of you can't get a job anywhere else, but you still want a lot of money, so how much do you want? We'll pay you it. We formed the Riverland Academy of Clinical Excellence. Not the Riverland Academy of second rate, but the Riverland Academy of Clinical Excellence. And we've put that into practice, and there's evidence, scientific evidence of how you actually put that into practice. And in 2 years, we have recruited 30 new Australian-trained doctors to our region. That's increased our medical workforce by over 25%. That makes a difference to models of care, to possibilities. What's been part of that clinical excellence. It's essentially been forming an academic health science network in our rural health service. 12 small rural hospitals, 12 general practices, community health services that Renee and others work in, associated with that. First of all, we've looked for where excellence already existed, and it's there. It's not trumpeted because it doesn't look the same as excellence in a tertiary hospital. I had to learn this when I became dean of a medical school as a primary care physician, rural generalist, primary care physician. I had to learn where I needed to respect my tertiary colleagues and where I needed to really trumpet their excellence, as well as trumpeting the excellence in primary care. Different, one not better than the other, but both important. So where was the excellence? We found that excellence. But we also realised that we needed to do some more things in order to be able to get that excellence. The first thing we needed to do was stop blaming everybody else for the fact that we couldn't get a workforce. The fact that we couldn't get a workforce was our fault. It was our fault because we had outsourced it to the city to develop that workforce. We'd said to the city, you go and train them and then we'll buy them off you. It doesn't work. So we took responsibility for training our own workforce as rural generalists because that's what we needed. And that's what those 30 doctors have come to us for, to become fellows of either the RACGP or ACRM. And they are now buying houses, having babies, living in our area. We don't provide accommodation subsidies. We don't provide any other subsidies. We just provide a fantastic job and a fantastic training that they don't have to go all over the country to get, with great teachers. 30 new doctors. So we take responsibility for training our own on country. Where did we get that principle? From Renee and her colleagues. Because what's the understanding of health that Aboriginal and Maori people have? It's bio-psycho-socio-spiritual understanding. And that spirit is related to country. But we've forgotten that in the Pākehā. We've said, you can train wherever you like and we'll just buy you in. No, where you train becomes part of your soul, becomes part of who you are, it becomes part of your country. So we've changed that. We've said we need to be accountable for our own workforce creation. But academic health science networks also need research. So we need to be accountable for our own research to create an evidence base of care that is suitable for our environment, not just taking it from Oxford or Cambridge and trying to translate that to where we are, but let's actually do that. And you've seen the way you can do that this morning, haven't you? You've seen the evidence of people in primary care publishing research. That is evidence of excellence. So what did we decide we needed to do in terms of that research? So, and this is where we are going to get onto diabetes, by the way. But it's the context which I think we can add to what, wonderful presentations we've already had here. And that context goes like this. If we're going to do research in a rural area, are we really just going to do second-rate little bits and pieces and get them published in non-indexed journals and blah, 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 blah? No. So we've partnered with people we think are the best, as long as they're doing something that we think is worthwhile in our region, and they're involving us as a chief investigator. So we've got augmented reality for ulcers. We've got AI-assisted mental health triage and referral systems. We've got CT coronary angiograms saving patients having to be moved to the city for negative coronary angiograms. saving the system money. So we've got all of that, and alongside all of those types of research, which are enormously respected by our tertiary colleagues, they look at those and say, this is real excellence. Alongside of that, we said, so what are we going to do to really make a difference to our health service and our community? And this is the hospital speaking. What are we going to do? 5% of our population are Aboriginal. They have the worst outcomes. Diabetes in particular is responsible for most of those worst outcomes. So what do we do as a researcher in that situation? The usual thing is we go out and count it, and we analyse what we've counted and we publish it in the Lancet. That's really good, isn't it? Fantastic research. And then we get someone else to come and count it again a year later. We make the comparisons. Really good. No, we didn't do that. What we said was, because what's that? That's basically saying Aboriginal First Nations, it's all about inferiority. It's all about disadvantage. We said, could it be that Aboriginal people actually have advantages over us Pākehā in terms of their health? And what if we actually worked with those strengths? Is there actually the possibility, we've read this stuff over in England, and we've read this stuff in the United States, and I've had some patients in my practice who've come off 210 units of insulin with their type 2 diabetes, and are now just, walking and leaping with joy. What if that happened for our whole Indigenous population? People say, well, shouldn't you do that for everyone? Well, why don't we do it for Aboriginal people first? Because they may actually be advantaged. So I'm going to leave you with that question. Why may Aboriginal people actually be advantaged and have a whole lot to teach us in terms of getting this to happen? So one of the things we did on that hypothesis that there was an advantage was we said, we're going to co-design this program. So rather than taking David's program, which we could have done, and we had links with Eric Westman at Duke University as well, and that was really important in terms of getting a grant from the NHMRC to do this, was to link with that sort of expertise. But just getting those programs and plonking them in an Indigenous community, was that going to work? No, so we decided we need to co-design this and work out how to co-design a program with our Aboriginal communities. So Renee's led that work. So Renee, what's the experience, living and growing up in a place called Rauken? You might want to tell people what Rauken is, and your sort of experience of diabetes in that community.
So Rauken is a small, about 150, 200 people community in the southeast of Adelaide. It was, to us, it's always been Rauken, but when colonisation, that's when they sent all the Aboriginal people from in the towns to Rauken, and they called it Point Macleay, but to us, it's always been Rauken, which means the meeting place. In my generation, I've always seen diabetes, funerals at super high rates, chronic health, people dying at a really young age. However, when we have our yarning circles, which is what we call when we sit and meet, and that's how we get our research, in my grandmother's age, there were nobody was sick. Diabetes and chronic health is a really new introduced way of living. That's not how they lived. Everybody was healthy. Food was healthy. They had their own ways of knowing, being, doing, and it was a healthy community.
2 generations ago, and there was no diabetes. That's not the case.
Roughly, absolutely roughly.
It's so. What was it about 2 generations ago compared to now with this change? What sort of foods was your grandma and her friends eating?
Fish, we'd go out and fish, kangaroo, swan eggs, Cape Barren geese, and there'd be exercise because you'd have to go out and catch it and find it. And then there was a real community sense, and that food was then brought back and it was shared. So food really brought the community together as well in a healthy way.
So Grant, fish, swan's eggs, kangaroo tail. What's the physiological state of those people?
I suppose you'd have to imagine that they were metabolically flexible, but more or less in constant nutritional ketosis.
So for the record, metabolically flexible and almost constant nutritional ketosis. 2 generations ago, no diabetes. You would have to think, genome, epigenome, etc., that there's genetic memory in our Aboriginal communities still of that way of life. So a lot of these issues that we have in Pakeha about how do we stay on this diet, how do we stay on this way of life, perhaps that's because for us, we've been living with industrialised food for far more generations than that. And our inherited epigenome is very different, has adapted, if you like, to food addiction issues, which weren't the case for our Aboriginal brothers and sisters. So we've been working with Aboriginal people to design programs with the aim, which will be starting in a couple of months, for a stepweeds trial, clinical trial. So what are some of the issues that have been raised by elders and other community members in terms of how we need to go about this trial and what we can do to support them and what they can do to support us?
A big one was cost and accessibility. So where we are, the 3 sites, in Rauken there's 0 supermarket whatsoever. So they have to travel, and then the cost of what that's going to cost. And a bit of shame as well, like recognising that there's a problem and wanting to fix that problem, I think was one as well.
So what ideas have they come up with to overcome those that we can implement?
So they came up with an idea of, and I don't know if you have it here, it's HelloFresh. And so they came up with their own idea of a HelloFresh where they would create their own recipe cards, and we could supply the food that they did. And so Paul reached out to sponsors, so local food producers, who agreed to supply 18 tonnes of meat for the trial. We've created our own community bush tucker gardens. So we started it, so then even when the research is over, the community take over, and they can do that. That was some of the things that we came up with. So they'll create the recipe cards, and then we just provide the food for that.
Pretty amazing, isn't it? Co-design. And I mentioned that it's almost like the bringing together of different communities around excellence. So that is excellence. But that excellence is not recognised by a lot of my colleagues in endocrinology, rheumatology, cardiology, neurology. So how do we link this excellence, which we all recognise, I just saw the looks on your faces, with the excellence that the rest of the system recognises? So one of the ways we've done that is we've reached out to a Hong Kong company who will donate continuous glucose monitors and continuous ketone monitors. Yeah, this will be the first time that the CKMs are used in Australia. and the first time they're used in Australia is not at Royal North Shore Hospital, it's at Rowcan. So it's that mixing of what is seen as excellence by our colleagues and what is seen as excellence by us. Just bringing that together, and like Jen and David and the others, we can answer questions over lunch, because we realise that we're keeping you from the opportunity to speak to these people over lunch, because you don't need lunch because you're all keto adapted.
I need lunch.
Just sort of summarising. So Marcus actually produced a wonderful paper which I read last night. Thank you. An ethnographic paper showing that at the point of colonisation, Maori men were described as taller than Europeans, thinner than Europeans, far more flexible and agile than Europeans. And having a look at the records, again from centuries of data, there was evidence that was essentially nutritional ketosis that people were living in. We had a criticism yesterday that despite David's 3 years of evidence, and Verta Health have 2 or 3 now years of evidence, people are saying, well, there's really no long-term evidence, is there? Despite the fact that Ozempic got registered with 6 months or 12 months or something like that. I disagree. We have 60,000 years. 60,000 years of evidence that nutritional ketosis is not only sustainable, but it actually produces health and well-being. And we can't forget that. Thank you.